So we've ended the first section, the headache section in the top left. And we're going to go on to another section, but you can go now and take a look. The six different signs and symptoms. 1, forehead. 2, temples. 3, migraine type. 4, sinus type. 5, shooting pain up the back of the head. 6, here, and scalp painful to the touch. That's the first section of the first section of the Kidney Fun Stack Visual Index. Okay, so now we're going to look in the eyes, and there are relationships between TMD and eyes. Probably the most common is pain behind the eyes, and this can be a big concern because the brain is behind the eyes. So wait a minute, is there a problem with the brain? Is it a brain tumor? What's going on? And they very often go to their ophthalmologist, their eye doctor, talk about the pain behind the eyes, and he says there's nothing wrong. I'm very, very sorry. And it's a TMD problem, and he knows nothing about TMD. It's hard enough to get the ear, nose, and throat doctors to learn, but to get an ophthalmologist to learn, kind of crazy. So where does this pain come from? And I'm going to say primarily the splenius cervicus muscle and pain referral. And the splenius cervical muscle is a muscle, get this, in the neck that doesn't attach to the head. It's in the neck. Oh my God. So a neck muscle that hurts like hell, that's trying to pull the head backward because it's too forward, goes into spasm and has pain, and the patient experiences pain behind the eyes. Okay? Now, here we go. The sternocleidomastoid, that bastard muscle, involved in so many things. The sternal division, remember there are two divisions, clavicle division and the sternum division. The sternal is in the middle of the chest. The sternal division sends some pain behind the eyes also. So we've got these two, but it's less pain, right? It's less. The temporalis muscle, this is a masticatory muscle, a dental chewing muscle on the side of the head. This can also cause pain behind the eyes. Lord Almighty, we've got 3 muscles right now, and 3 of those muscles can cause pain behind the eyes. All these muscles are involved in TMD. Next is the superficial masseter muscle pain, and the masseter is the most common muscle involved in TMD. We screen for it when we do our consultations, and we determine how good our treatment is when we see the masseter quiet and happy. We've done a good job of treating that patient. And there are 2 layers, superficial, which is the outer layer, deep is inner layer. The superficial masseter muscle will refer pain behind the eyes. So we've got, 2 masticatory dental muscles. These are dentist's muscles, temporalis muscle and the superficial masseter. Trapezius muscle we've talked about before, big triangular muscle on the back of the head, going all the way down to the tips, the shoulder, right? And then going down the back. That muscle usually involved in pulling the head back, and that muscle will cause pain behind the eyes. Sub means under. Occipital is the back of the head. Suboccipital muscle pain referral. And remember we said occipital is the back of the head. The occipital bone is the one in the back bottom of the skull. The occipital muscle pain, that will refer. And then finally, the orbicularis oculi. There's a circular round muscle that when it contracts, closes the eye, shut. That is the orbicularis oculi. Orbicularis means round or orbit. Oculi means eye. Orbicularis oculi, muscle, pain, referral. And then, of course, unfortunately, could be we have a brain tumor or some sort of pathology in the eye itself that can cause pain behind the eyes. But most commonly, we're going to say 90% of the time, it's one of these muscles. So another symptom, again, a symptom is something that the patient sees, doesn't want. Uh, we see sometimes bloodshot eyes, and it looks like they were drunk or up all night or something. And this is what we call an autonomic referral. What does this mean? A muscle sends a negative signal into the brain saying, ouch, ouch, ouch. And the brain, the nerves in the brain that control the eye, uh, send out signals outward to the eye and causing problems, what we call autonomic or automatic things that occur from nerves. We have uh, the parasympathetic, which is fight, rest and relax, and the sympathetic system, nervous system, which is fight or flight. These two nervous systems, you can look them up, they are influenced by constant pain from muscles. And so the bloodshot eyes can occur with TMD. Now, another thing, there's two other things. Cluster headache, which is a terrible headache. I think it's called suicide headache. It primarily affects men. They're on one side of their face, their eyes can turn bloodshot, and they talk about terrible pain, very often happening in the evening at a certain time. That is not TMD, but it is related to TMD because it is the same nerve, the trigeminal nerve. And then, of course, bloodshot eyes can occur from bacterial infection. We don't want to confuse that. We start treating TMD thinking that this is a TMD symptom when in fact it could be a bacterial infection. This is why we always have to have a multi-discipline. Multi means many, discipline means different professions, medical profession, ENT, ophthalmologists, right? Neurologists, nerve doctors. We use a multidisciplinary treatment protocol that gives patients relief. And this patient has beautiful eyes, like blue, and then the center part's a little brown. So she probably has a parent that has brown eyes and a parent that has blue eyes. But look in the white part of the eye. You can see a bunch of blood vessels. Blood is red, and there's little pathways like rivers all over the place. That's bloodshot eyes. So this is an interesting symptom. I don't see it that often, but if you look at this patient's left eye, it pushes out, right? It bulges out, bulging eyes. It's called exo means out, like an exoskeleton, a skeleton on the outside rather than the inside. Endoskeletons inside, exoskeleton's outside. Exophthalmos, ophthalmology is the study of the eye. Exophthalmos is the bulging of an eye. And to me, I haven't seen this, perhaps because it's very often two eyes that are bulging and it looks symmetrical, but this person has asymmetrical, meaning the right eye is much different from the left. She would have headache on her left side, but she probably has a thyroid problem. If you look at her neck, it's swollen out, and that is a sign of thyroid disease. However, only one eye being affected is very unusual. Usually two eyes are affected. In China, they say if an eye bulges out, you can see the white of the eye above, all around. The person's crazy. And that is true. That is a sign of insanity in China, and it's a Chinese sign, and meaning that you can see the eye, but all the whites are seen too, top, bottom, left, and right. Again, eyes. Uh, and this one worries me a little bit because it creates a lot of confusion, right? Sensitivity to light, to sunlight. You'll see some patients occasionally come in with sunglasses in the inside of the office, and they wear sunglasses. And you ask them, why you wearing that? It says, it's just really bright in here. They are sensitive. And that comes from, again, remember we said there are two nervous systems, in the autonomic system, the parasympathetic, the sympathetic. This is computer program nerves that are programmed through the brain that do various things. Autonomic means automatic. You don't think about it, you don't control it. And the muscles that get pissed off with what we call trigger points will refer pain into the nervous system, the brain, and then out comes the sympathetic system. Sympathetic is fight or flight. So you're ready to fight the dinosaur. So you do not need to see the little details of the dinosaur. You need to see any movement of the dinosaur. So your eyes dilate, get bigger, your pupils dilate so you can see more. Because you're fighting and running, you don't need to see detail. So when your eye closes down very fine, you see more detail. When it opens up, you get more sunlight in, but this is the problem. If they stay dilated, then we've got a little bit of a problem. And I see that. I saw a patient yesterday that even when I put light in, didn't constrict. The pupil didn't go down to normal. It's dilated. All right. So trigger point, autonomic, sympathetic, pupil dilation. Sympathetic means they are fearful. They are fighting. Right. And it could reflect a serious I don't want to say mental problem, but they're involved in a fight, and their mind is believing that they're still in Afghanistan fighting, or they were getting raped when they were a kid, and they are still being raped, even though it's not happening. But their brain still thinks that it's happening, and their eyes dilate. And then another thing is, some primary headaches. There's a whole categorization. Central sensitization means that you are overreacting to a stimulus, something happening like touching you. Whoop, you pull away really quick. Central sensitization is when basically the nervous system gets shot and it responds really dramatically, very quickly to anything that normally would not be a big problem, right? But in fact, the cause of photophobia, if you have a phobia, you're afraid of something, photo means light, like a photography. Graphy means writing, so photography means light writing. And photophobia really is not known. We don't know exactly why, but we do know it seems to have something to do with trigger points. So again, you are going to be an expert. You should know, you're taking this course to know all the signs and symptoms of TMD. A sign is something you see the patient doesn't complain of. They may not even know they have it. A symptom is something the patient complains of and says, I want to get rid of this. It's pissing me off. And so we're going through these signs and symptoms. We finished 2 sections, the head pain, headache, which in the forehead, temples, migraine type pain, sinus pain, shooting pain up the back of the head, here and or scalp, painful to touch. Again, if we remember, that might be related to central sensitization that we talked about in the eyes. Then the eyes, pain behind the eyes, bloodshot eyes, and bulging eyes, and sensitive to sunlight. And something I didn't talk about is migraine tends to have sensitivity to the light and pain on the side of the head, and so doesn't TMD. Oh my God. That is one of the reasons why there's so much confusion, especially since physicians do not lay hands on patients anymore. They do not do what we call physical diagnosis. And TMD people touch people all the time. You'll see me touching my patients because I want to get rid of all the musculoskeletal dysfunction. Dys means bad, function means how things are done. So now we're going to enter into the dental sphere, the dental part, and we're going to go into the mouth. Got it? So mouth discomfort. Dis means bad. Comfort means liking something, relaxed and happy with it. Discomfort means bad relaxation, not being able to relax. And this discomfort can come from actual myalgia. Myo means muscle, algia means pain. So masticatory muscle myalgia. And you should know all the 4 primary masticatory muscles, which are what? The masseter, temporalis, medial pterygoid and lateral pterygoid. You should look those up and look at the anatomy and know what they do when they shorten and contract and what kind of motion they create on the lower jaw. And you can actually have pain in your joint, one or both temporomandibular joints, the jaw joints, and when you move, it hurts, so it's uncomfortable. So the joint pain, muscle pain, and then another thing that happens, I want you to understand this because it's really complicated. All right, so when you're walking, one foot goes, the other one relaxes, then the other foot goes, that one up, and the first one relaxes. There is a program, think about this, the brain is programming each movement left and right. Wait a minute, you stop and you go forward. Okay, now you stop going forward, you other one go forward, and there is a coordination computer like a car moving, and there is a program for that, okay? And then proprio means own, ception means to take in information. So proprioception is knowing where you are in space. And then sometimes these patients, because of the pain and the joint issues, they do not know where their jaws are. And you will see this sometimes when we are doing what we call exercise 1 with the hard appliance, the 3D mandibular orthopedic repositioning appliance. It's key that the patient learns the therapeutic bite, because at that therapeutic therapy bite, their joints are in the correct place and they start healing. But they can't. They don't know where it is. And that is proprioceptive dysregulation. One of the things I do when I teach is say, okay, stand up, close your eyes, take the finger in your the finger in your right hand and put it on your nose. Now your eyes are closed, but your brain knows where your nose is. It knows it. There's a little man or woman inside you and your brain knows where your nose is, and it really does. Exactly where your nose is. Wait a minute. Your brain knows where the finger is, and get this, anywhere that you move your hand, it knows where that finger is in space. And then like a missile program during, the Iraqi war, they had these missiles going right through the front door, bunkers and things. That tip of the finger goes exactly to the tip of the nose with your eyes closed. Well, how's that happen? That's amazing. It really is truly amazing. Because your brain knows where the finger is, your brain knows where the nose tip is, and it can put them together very easily, right? And that is proprioceptive regulation. Proprio means to know where things are. And these patients have pain a lot. Sometimes, especially when they're older, they don't know where their jaw is. Isn't that crazy? And you'll see that. And we're doing a therapeutic bite, and they can't get there. They don't know where it is. They have to have a mirror to see when they bite down where they are, and we try to reteach them the proprioception, reteach them to see where their lower jaw is. So this is crazy, one of the most common symptoms that we see in TMD, and the one that dentists pick up, right? This is easy. Most dentists know nothing about TMD, but they know if a person can't open, they probably have TMD. So what does this mean? It means that we get a lot of referrals from people that can't open their mouth, right? And how does this happen? Well, if a muscle goes into spasm, if you've ever seen a weightlifter after he weights, he can't move, right? Boom, boom, left and right, like they're like some sort of ape, and they can't move anything. So if the masseter muscle, masseter is a powerful closing muscle. So if it goes into spasm, it wants to close your mouth and you can't open it. The medial pterygoid muscle, that's on the inside. So the masseter's on the outside of the jaw, medial pterygoid's on the inside of the jaw, right? It's like two ropes on a swing, a play swing where kids get on. And trismus means shortening and being very tight. Very often when dentists do a dental injection, they have to go into the back of the jaw to go into the entrance of where the nerve to the lower teeth are, right? And they take their needle and they go in and they try to numb what they call the inferior alveolar nerve. And that's the one we numb to put the lower jaw to sleep. And when they inject in, they have to pass through the medial pterygoid muscle. And sometimes, instead of going all the way through onto the bone underneath where the nerve is, they are premature. Means too early. And they inject their anesthetic into the medial pterygoid. And I'm telling you, there is something called necrosis. In other words, death of some of the muscle tissue. And the medial pterygoid clamps up and hurts whenever it moves. So after a dental procedure, some of the local anesthetic, the lidocaine, can accidentally get into the muscle, and the epinephrine inside the anesthetic is what causes the death of the tissue and pain. So the temporalis muscle is also a powerful closer. So get this, you got 3 closers of the lower jaw: masseter, medial pterygoid, and the temporalis. These are all closers. And when they get really tight, trismus, then you can't open, all right? The anterior displacement without reduction, this is called a closed lock, and we see maybe 1 a month where there's so much damage inside the disc that goes between the upper jaw and the lower jaw that slips out of place so badly that it does not go back into place. Going back into place is called reduction. When a orthopedic surgeon, a doctor, you break your leg, he puts the leg back into place. We call that a reduction of the fracture, right? That means putting the bones back into place. The bones are reduced. They're called reduction. And without reduction means, hey, that disc is not going back into place. Anterior means forward, and the disc goes forward, out of place, and does not go back into place, and the person cannot open their jaw, even though those muscles might be fine, right? There's also ligaments they hold bones together, and there is a ligament on the inside of the jaw called the sphenomandibular ligament. That ligament can also be damaged with injections, and when a ligament gets hurt, it won't let the jaw open. Once in a while, we get patients that have teeny tiny little mouths. The hole, around their lips is so small, it is hard to get anything into it. And it's called micro, means small. Stomato means the mouth opening, the mouth itself. So we do see patients like this occasionally, as it's very difficult to work with them. But I'm getting worried because infections are getting worse and worse, and the discovery of new antibiotics is getting slower and slower, and we are starting to see mother infections. We're starting to see very bad infections occurring, and I predict there are going to be deaths. I really do. I'm telling you right now. It's going to happen, and it's going to be around dental, and there's going to be huge lawsuits because if you look at oral surgery textbooks before 1940, around 1940 is when penicillin started being used a lot. This is World War II. But prior to that, there were deaths all the time from dental. One of the WB, Warner Brothers, the WB, this is the big movie company, one of the brothers died of third molar infection. And this happens. So if infection spreads into any of the muscles, and these closing muscles, they can't open. And I've seen this a lot. I'm starting to see 1 a month. I worry. There will be deaths, and I don't want to be on the receiving end, and I certainly don't want my patients to die. So we have to be very, very careful about this. And radiation therapy basically destroys the muscles, tightens the muscles, and what we call scleroses the muscles, so that they become very more collagen, and they're dry, and they can't function like real muscles, and they limit the mouth opening also. So it's a big section here because we see a lot of this. with TMD patients. I think the dental assistant should pay a lot of attention to this particular diagram. The lower jaw is called the mandible. A range is one point to another point, right? So when a cannon fires, its maximum amount that cannonball can go is at the end of the range. So the range would start from the cannon all the way to the end, and you measure it in feet, and that's the range of the cannon. The better the cannon, the longer it's going to go, right? So we have mandibular range of motion. Motion means movements, right? So when a person opens, they should open 40 to 50 millimeters. We get a lot of controversies, well, some controversy, and I can sit and talk with you someday, but all we're doing is interincisal. We're measuring from the edge of the upper tooth, central incisor, to the edge of the lower central incisor. And you put a millimeter ruler there, and you measure it and record it. Right lateral means movement to the right as far as possible. Left lateral means movement to the left as far as possible, and you're measuring this movement with a millimeter ruler. We use a Miltex endodontic root canal metal millimeter ruler. Protrusive means pushing forward, and that can vary dramatically, and I don't really even look at protrusive. I probably should, because there is, an anatomical basis of that, but I am really concerned about right and left movements. And the lower jaw rotates like a bicycle wheel from 1 millimeter to 25 millimeters. Memorize that 25 millimeters. All right. So a person, even if they have anterior displaced disc without reduction, remember we said a closed lock and they can't open, we know they can open at least 25 millimeters because they can rotate inside the socket and not go forward. Going forward, sliding forward is called translation. We know we can get them open to 25, and typically 25, if we relax the muscles, is enough to get a lower alginate impression. But we measure mandibular range of motion at every single appointment. Why? Because I am function oriented. I want my patients to function. I want them to be able to chew, to talk, and if they can move right, then they're right. All right, that's how I think. If the movements are normal, they're normal. All right, there could be other problems happening, but one of my primary goals is to be able to speak, to be able to eat, right, swallow, move that jaw around normally, and these are the measurements that we aim for in our treatment. It gives me what they call objective, means a measurable way of seeing if I am successful. So sometimes patients will say, oh, I haven't changed. And I get pissed because they came in opening 28 millimeters. Now they're at 40, and they say, I haven't changed. And I can see that they're getting much better, right? But some of the hurt hasn't healed yet, but the motion is returning to normal. And if the motion returns to normal, they will eventually get to normal. That's my opinion, unless we have a neck problem complicating things. If you see someone walking and jerking or leaning forward or hobbling, you know there's a problem, right? They can't walk correctly. They can't pick something up correctly. That's a problem, right? The body should move smoothly, easily, without any problems. However, we very often will see people open their mouth and go to the left and then jerk to the right and then jerk back to the left, all this weird movement. And they need to be able to open smoothly, but they can't because very often they will have joint problems. And we can, in a more advanced course, we can discuss these joint problems and why they occur. But for now, the damage inside the joint, intra-articular dysplasia, that can cause jerky movements from inside the actual joint. Sometimes one muscle, like one masseter, the right masseter will be very tight, the left will not. Okay, please listen to me. So if the right masseter is tight and shortened, it is not the right length. We want to lengthen it. Listen. I hope you're going to get this, because so many dentists screw up in this area completely because they don't understand what I'm about to teach you. So the left mass is normal and hangs, and the right is pulled very tight and shortened. So when they open, they go a little bit to the painful muscle that's shortened. And so that will cause deviation. But when you put an appliance in and they close, it's going to hit the shortened muscle first. And you want to stretch that muscle open. So you do not want to cut the soft guard, let's say, shorter because it's already shortened. So you leave the soft guard at its normal and don't adjust both sides even, because if you adjust both sides even, it means you are keeping the shortened muscle length and you want to lengthen that muscle. So the distance between the upper teeth and the lower teeth are even on both sides. So when you're delivering a soft guard, you do not adjust it so that it hits on both sides, because one side is shortened and you don't want to adjust the appliance to the shortened side. You want it to lengthen. I hope this makes sense. I really do. It may involve a more extensive discussion, but it's extremely important not to adjust a soft guard that's hitting on one side, because it's hitting on that side because the muscle's shortened. It's hitting prematurely because the muscle's shortened and you want to lengthen that muscle. So you don't want to adjust it. You don't want to shorten or grind on it. You don't want to grind on a soft guard at delivery because it's hitting prematurely on one side, because that's the side that has the shortened muscle, and you want that muscle to lengthen and become normal. And when it does, it won't hit prematurely anymore. Okay? So asymmetrical means not both sides. So asymmetrical means one side masticatory muscle shortening. And sometimes you can have muscle length discrepancies because of the skull problems, right? Asymmetrical skull, one eye is higher than the other, one ear is higher than the other, the jaw is twisted to one side. That means that those muscles on the right and left side, they cannot be the same length. They cannot be the same direction. And we want symmetry. Symmetry is wonderful. Olympic athletes, when they're measured, have almost perfect symmetry. This is true. So we know that ideal function requires ideal symmetry if possible, and we're aiming at symmetry. So we do know when patients present to us that they are asymmetrical, they're kind of twisted up, right? They have cranial distortions, their skull is twisted up, and we're trying to unravel that skull, right? Osteopaths, which are doctors of medicine, DOs, doctors of osteopathy, they have medical licenses just like MDs. They believe that the skull distorts, gets locked, and doesn't function properly in some patients and causes a lot of problems. So, and sometimes there's just nerve problems. The nerves don't fire at the right time. It's kind of like a car that needs a tune-up because the carburetor is not hitting correctly. It's not firing when it's supposed to, so you get a jerky drive. And you have inhibition of proprioception, meaning that there's something that's stopping the body from sensing itself. And then there's also inhibition of motor functions. This means that there is a nucleus inside the brain. That's a clump of cells. That's the central thought. That's the computer area that moves the jaw around, right? The part of the brain stem that moves the jaw around is called the motor nucleus, right? That's a nerve term, and it's part of the central nervous system. Central means the middle. And that central nervous system can get messed up so that you can't chew because you can't fire correctly. The brain inside the part of the brain that causes chewing, it's just not working well. One of my sons had a Honda, and the Honda works on a little computer, right? All the engine and everything, the electrical system. And that one day, that little electrical box misfired and dysfunctioned, and the car went dead on the highway while it was moving, right? This is kind of what happens with the inhibition of motor function when there's something problem with the brain. Not that there's a tumor, but just that the brain is not cycling correctly, its program has a problem, right? So sometimes what do we do when someone has a heart attack? We shock them to reset the pace of the heart, right? So that the heart will beat. And we're basically, when we put an appliance in, we're resetting the nervous system. A very common symptom is when the patient opens their mouth, and normally when you open a door, it slides open, slides shut, nice. But these particular patients, their jaw goes to one side. It doesn't open straight, opens to one side. And that can happen when the disc inside one of the joints doesn't move correctly. It slips forward, anteriorly is forward. Anterior disc displacement is displace. Place is where you are. Displace is not a good place to be in, like disorder, bad order. Um, but an anterior disc displacement will cause someone to deviate to one side. And then also, and we talked about this before, like one masseter muscle, beaver muscle, could be very tight and hurtful, painful. And because it's painful, it doesn't work well. So you can actually, it won't open. So you'll deviate towards the painful muscle, and that comes from one muscle being tight and the other not. That's asymmetry. Symmetry means beautiful, the same on both sides. Asymmetry means not the same on both sides. It isn't uncommon. Probably once or twice a month, we have what we call a closed lock. Closed lock. Lock means the door doesn't open, right? Um, Closed lock is when they cannot open their mouth, right? They cannot translate or slide. They can rotate inside the socket, but they can't slide. So they can open maybe 25 millimeters when the muscles are relaxed, but typically when they slam shut like that, the disc goes forward, all the muscles tense up bad, and they cannot open. All right. And if they cannot open because of a disc displacing, go out of place forward, we call that an anterior disc displacement without reduction, meaning it doesn't, reduction means going back into place. Without reduction means it doesn't go back in place. So that stupid disc is out of place, completely forward, off of the condyle, and it's just not where it's supposed to be. We do have what we call transient. Now, transient means it happens and then it goes away. It happens and goes away. So patients will talk to you about transient anterior disc displacement without reduction. So anterior disc displacement without reduction, they can't open, and it doesn't matter today, tomorrow, tonight, they can't open, right? Transient means that, oh, they can't open, and then they jerk their jaw right and left around, and they hear a big mother pop, pop, and that means the disc is going back into place, and they can open again normal. So this happens, then goes away, and then happens and goes away, and then locks and goes away. So they're locked, they're normal, they're locked, they're normal. That is transient anterior disc displacement without reduction. And this typically comes before a permanent lock. In other words, they will tell you, oh, well, I would get up sometimes and I couldn't open, and I moved my jaw around, and then it would pop and I would open. And here's the problem. Every time that happened, they're pulling on the ligaments. So a ligament is a rope made out of collagen, and it holds the disc in place, right? So the disc is held in place by these ropes called ligaments. These ligaments, these ropes, just like, ropes, if you pull them, they don't come back. They're always pulled. So if they're like 5 feet and you pull it really hard, it goes to 6 feet. It never goes back to 5 feet, which means now that disc isn't held in place really well, really tight, because all the ligaments are shot. And this is a big problem because a lot of patients, they say, well, I don't like this clicking, but they have damage in the ligaments. And they may have that clicking forever. Maybe half of the patients, that we treat, the clicking will go away. And we have a current elderly patient right now who didn't like the clicking, and we told her, this is about 50% chance of getting rid of it. And after 3 months, it didn't get rid of it. She got mad as hell, drove down to her dentist's office, trashed me in front of the dentist. The dentist called me, and it was just one of those terrible things that, geez Louise, crazy lady going nuts on me. And she had too high expectations. I never gave that to her. And when you have a damaged disc, when you out of shape, not shaped correctly, smashed up, and then ligaments that are all ripped and lengthened, you may not be able to make that go back into place correctly. We can't make her 16 years old again. However, we do have a good percentage success. So again, I taught you a little bit, when you talk to patients and you hear them saying, well, yeah, I couldn't open, and then I move around and heard a pop and it could open, that's transient. And if they come in, they can't open at all, and it's been like that for 2 days, that's the anterior displaced disc without reduction. Now, another lock is when someone opens so much that their condyle comes completely out of the joint, right? It's not in the joint anymore. And if you look at the side of their face, right in front of the ear where the joint is, there's an indentation. And it's an indentation because the condyle, that is the part of the lower jaw that fits into the temporal mandibular joint, it's not even there anymore. It's completely out. The car is out of the garage completely. And that is an open lock. These people cannot close because they've come out of joint, and the joint doesn't work because it's not a joint anymore. It's not together, right? It doesn't work together. That is an open lock. Uh, some people, right, they lose perception. They can't feel anything or see anything. It's kind of like if you're in a room and the lights are completely off and you just don't know where anything is. You're confused, right? And it sounds crazy, but some patients lose their sense of where their jaw is. All right. So in your body, in your brain, it knows where everything is. Previously, I talked to you about you closing your eyes and taking your finger and touching your nose. You know where your nose is. You know where your finger is. Everything, you know it. Your body knows where everything is. But these people sometimes will lose their sense of where things are supposed to be. And that is bad because all the programming in the brain is meant to chew. They're supposed to be able to chew food, eat the food, swallow the food, but these people are incoordinated and they don't know where anything is. Neuro means nerves and muscles means like muscular. So neuromuscular means the working together of the nerves and the muscles. Remember, the nerves are the wires that go to the muscle that tell the muscles what to do. And then you got a computer called the brain stem, which is part of the brain, and all of that coordinates and works together in a wonderful harmony, kind of like an orchestra, because every little movement, every single muscle in the body is controlled by the brain and by the brain stem, and all this is dictated by the nervous system. So it's possible that the brain is not allowing proprioception. Proprio means yourself. Ception means knowing where you are. Proprioception is knowing where you are, right? And then also, it may be some reason why the body is saying, don't do this. Do not open. Don't open. And so as the patient tries to do something, the body is telling it otherwise. So don't do that. And so there's this huge confusion, and there's very little to no function. And if a patient bruxes, this is called grinding of the teeth, movement grinding, bruxism. And I believe that is because when teeth touch, there is a reflex. So if I take a little hammer and hit your knee, your knees will go flying forward automatically. You won't even know it. It's a reflex. Automatic, happens without your knowledge, right? Whenever the upper and lower back teeth touch, your masseter muscle clenches. It's called the masseter reflex. And because you don't want a small animal in there alive, you want to kill it right away. It's just automatic. and a fish or whatever it might be that's in there that's alive, kill it right away. Your body is programmed to do that. But as people grind their teeth get flattened, and of course the teeth don't fit anywhere because two flat surfaces don't lock together, they just slide around. And people that brush or grind their teeth all the time very often have flattened teeth, and it's hard to find the bite there also. But again, what is the complaint of the patient? Well, I just can't find my bite. I don't know where to bite down.